So it's now my pleasure to introduce Dr. Heather Walkley, who is Professor of Medicine and Chief of the Division of Oncology at Stanford University and also Deputy Director of the Stanford Cancer Institute. She's also served as past President of the ISLAC and is Fellow of the American Society of Clinical Oncology. So she will be giving a talk now on a North American perspective on the place of chemotherapy in EGFR mutated and ALK translocated resectable non-small cell lung cancer. Welcome.
Thank you. Thanks very much. Do you want the clicker or is there, oh, right here. Perfect. Thank you. All right. That'll make it better than me just talking at all of you. You get to see slides. Good. All right. Thanks. I wanted to thank John for inviting me and thank everyone for being here. So we just had an outstanding overview by Professor Zhang about this topic. So I'm going to spin it a little bit differently from the North American perspective. First, my declaration, learning objectives, but you've already heard those. Okay. So you've just seen this. We know that ADAURA was very positive and ELINA was very positive. But my question is about the chemo, not about the TKIs and what they add. So to remind you about ADAURA, this study allowed patients to either get or not get chemotherapy, and that was at the discretion of the physician in consultation with the patient. And when we look at these curves, which we've seen before, we know that the disease-free survival was striking, though after 3 years we can discuss that curve. And we know that overall survival was striking, acknowledging that the patients on osimertinib continued it up to 3 years, and we don't have a lot of follow-up for patients beyond that time. But what about with and without adjuvant chemotherapy, right? That's the question. So if you look at this curve, you're going to say, well, I don't see any difference between those, and if anything, those patients who didn't get chemotherapy look like they're doing better. But that misses the whole point of who are these patients. This wasn't a randomized question about whether or not you got chemotherapy. The chemotherapy was selected, and these are very different groups of patients. So we can't look at this as says the chemo doesn't really matter. We have to look at this and say the chemo was probably really important for the patients who got it. So to say that a little bit more clearly, because we haven't seen those curves broken down by other things, we have to remember there are a lot of really important prognostic factors when we talk about lung cancer. We've just heard an overview of many of them. But by far the most important remains stage. We've known about stage for a long time. We keep modifying it and improving it, but stage is really critical. And a patient with stage 1B disease, we've known that we've cured the majority of them, or our surgeons have, or our radiation oncologists have, with a little help from the medical oncologist for a long time, right? But the stage 3 patients, those are the ones that need the most help. So when we look at this, 26% of patients with stage 1B got chemotherapy. Now for the medical oncologist, which stage 1B patients do you give chemotherapy to? They're not the ones you think are going to do well, right? And then for the stage 3, it was 80%, close to that for the stage 2. So the with and without chemo, those are very different groups of patients. And we don't have a lot of data breaking this down recently, but there was this presentation by Yilang Wu, also from Guangzhou, in 2020. So 2020, 4 years ago, most of those patients who were on the osimertinib arm were still getting it, right? Keep that in mind. And we look at the with and without chemo, we see that the patients who got chemo were the ones on the control arm were dropping off pretty quickly with progression because those were the stage 3 patients, so we expected that. And that those who didn't get chemo were doing okay because a lot of those were stage 1. And those getting OC were all still getting OC. And when we look at that by stage, it just tells that question very more clearly. So at the top, you've got your stage 3 patients. So everybody who wasn't getting osimertinib was progressing pretty quickly, as we would expect, because we know we cure very few stage 3 patients just with surgery and chemotherapy. And those who were stage 1 or in stage 2, some of them were doing okay, as we would have expected. So kind of putting all this into numbers, I realize that you're not going to be able to read that from the back of the room. I can sort of read it from here. But the key point is that for this stage by stage 3, stage 2, and stage 1, for all of them, getting osimertinib was better than not getting osimertinib. That part's clear. But when we look at what was that median disease-free survival on the placebo arm, how much did the chemo add, that kind of reinforces what we've already known from adjuvant trials of chemo for quite a long time, like 2 decades. All right, so I'm not going to floor it too, and just like Dr. Zhang, we're going to jump into a little bit of the metastatic world to get some more data. So for those of you who aren't medical oncologists and used to quoting this all the time now, this was a trial that looked at giving osimertinib with chemotherapy in patients with metastatic disease up front. So adding the chemo to the osimertinib for patients with metastatic disease. And this was a positive trial, as expected, for disease-free survival, because you're adding progression-free, you're adding everything together. But what they looked at also was, well, okay, if you give both things at the beginning, so concurrently versus sequentially, what does that really mean if everyone's gotten both of those things, right? So what's that progression-free survival to? What's that overall survival? Are those impacted? And we've seen some more recent data that actually they might have been. That actually your progression-free survival too was better when you gave the osimertinib and the chemotherapy versus just osimertinib. And maybe those survival curve is separating. It's a little early, but interesting, right? So I bring that up in this question of what does the chemo add to the osimertinib, maybe in adjuvant setting if it does something for for metastatic. So for EGFR, chemotherapy plays an important role, in my mind, for early-stage resected non-small cell lung cancer with an EGFR mutation. Osimertinib absolutely suppresses persistent disease, but we don't yet prove that it changes cure. And the slope of the curves with chemo does seem to flatten. That without does not. Now, osimertinib, when it stopped, does seem to continue to drop. Again, we need longer-term follow-up to say that. In North America, from my perspective, the decision for chemotherapy in early stage is made independently of the decision about osimertinib. And most do suggest it for stage 3 and stage 2. The duration of osimertinib is another question, and I wasn't asked to fully address that today, so I'm not going to jump into that one too much, okay. And then the ctDNA. So Dr. Zhang also talked about, Professor Zhang, about ctDNA, and I do think that's important. We'll talk about that in a bit. Okay, so just very briefly, Lena, you already saw the curve. A reminder, no chemo on the alectinib arm, none. For stage 3 patients, no chemo. And they only got 2 years of treatment. So think about that, 2 years treatment, stage 3 patients, no chemo. And of course, these curves separate beautifully because at the time point that we're looking at, most of the patients on alectinib are still on alectinib, but when you get out to that 24 months, maybe things are starting to drop. And if the chemo arm, maybe things are starting to plateau, right? These are the questions we have to look at. That's the subtlety, and that's what's important when we're talking to our patients about what to do. When we look at that disease-free survival by stage, and we look at those getting chemotherapy, that's the red, and those getting alectinib, that's the blue. For the red, maybe curving straight, maybe not, right? For the blue, everyone's doing really, really well during those 2 years are on alectinib with early stage disease. But we kind of already know that from patients with metastatic disease getting ALK TKIs. They work really well. In the first line setting, we now have an ALK TKI that had 60% of patients at 5 years still on their first line ALK TKI with lorlatinib. I'm not showing you those curves. So with crizotinib, you know, it looked much better than chemo. We learned that forever ago. And we know that alectinib is better than crizotinib, and about 10 other ALK TKIs are better than crizotinib, right? Again, sorry, but we've seen that study a few times, okay? And we also see that it's kind of flattening a little, which is surprising. These are metastatic patients, so it's not surprising that 2 years of alectinib is better than chemotherapy. But again, we're trying to cure people, and we're trying not to overtreat people. So chemo, I think, plays an important role in resected early-stage lung cancer with an ALK translocation. I know that wasn't the trial design, and we're not sure what the labels will be. Alectinib suppresses persistent disease, no question, but we need to know if it's actually curing. We haven't seen that. I'm suspecting not. But we'll get to some data that came out at ASCO this year that had me question that a little bit more. Chemotherapy should be considered for stage 2 and 3 and some stage 1B because chemotherapy can cure. We've proven that a long time ago. The slope of the curves may be critical, but we need enough time to know what those curves are. And in North America, the decision for chemotherapy, I still think remains independent of our choice of a TKI. And we should use TKIs for EGFR, and we should use TKIs for ALK. I'm not arguing against that, but I think there's still a role for chemo. And the duration of alectinib is another important question, which I have said loudly to many people. Okay, So can adjuvant therapy be individualized based on risk? And this was a beautiful slide that Ben Solomon put together in his discussion at ASCO last year of the ADORA data. So there are some patients who are cured with surgery alone. You know, surgeons, give yourselves a round of applause. You've been curing lung cancer for many, many years, right? And radiation oncologists have too. So we don't need to treat those patients. Or are those with the driver mutations different, right? That's the question we don't know. And then there's some patients who need more than what we're doing. So this beautiful analysis from ADORA, we've seen lots and lots of ctDNA data. Most of it that's come out of our adjuvant trials so far is not personalized. It's not sensitive and specific enough. It's just prognostic. This data from ADORA was the first where it's a large trial where they've used a truly personalized, tumor-informed ctDNA assay. And they did multiple time courses. So this, again, was presented just at ASCO by Tom John. And what they showed was not surprising. The patients who were getting osimertinib had very few recurrences while they were, or very few evidence of ctDNA recurrence, and very few patients who had disease progression, versus those getting the placebo after the chemo had more patients who recurred and more patients with ctDNA. You can't see that slide very well. There's a lot of red on the bottom, and the red is the patients who had MRD detection, okay? For the patients who had ctDNA detection, it showed up before disease progression on the order of 4 to 5 months early. We've seen that in other analyses, but again, this was personalized, tumor-informed, so more sensitive and more specific. But when you look at all those numbers, what was the true sensitivity, specificity, positive predictive value? They're better than what we've seen before, but they're not really great. It wouldn't be enough for me to make a choice about what to do for the patient, but it's moved us closer to that point. And what this is showing is those getting osimertinib, those getting placebo. On the placebo arm, the majority of patients have had evidence of MRD, of detection of ctDNA, and of tumor recurrence, though a third were cured without getting the osimertinib, potentially. And when we look at the blue, the other side, the osimertinib, we see most of those patients, their cancer hasn't come back, but for those who did, most of it happened after the osimertinib was stopped. That's that light green. All right, so putting it all together, the ADORA MRD analysis at 24 months post osimertinib and placebo, so this is at the 5-year mark, so patients have been off of treatment for the most part, with an assay that has a positive predictive or sensitivity of about 65, negative predictive specificity about 95, positive predictive value of 91, right? So good, but not super fabulous. Dr. John and colleagues were able to show, and remember, 60% of these patients had chemo. So 60% had chemo, very different than no chemo. But about a third of those on the placebo arm never had MRD, never had a recurrence. They were cured. And about 60% of those in the osimertinib arm never had residual disease, no disease-free survival at 5 years, so 2 years of off of therapy. So that was probably, to me, the most eye-opening, because I've been very much a very loud, OC's not curing them, we should continue it indefinitely. But that data got me thinking, maybe that chemo made enough of a difference with that OC that we don't need to do this. So there's some questions that we still need to answer. So maybe we're over-treating 30% of patients with the osimertinib. And maybe we're stopping therapy where we should, like for 30%. Maybe we didn't even need it for some of them. So we need better assays, and we need to delineate who are these different groups of patients much better. We need to understand how the chemotherapy component plays a role for these folks. So in conclusion, chemotherapy plays an important role, in my mind, in resected early-stage lung cancer. The TKIs suppress disease, but do they cure, right? Different than at the beginning when I said they don't. Maybe they do. Maybe they are actually curing some patients. What is the optimal duration, though? Chemotherapy can cure. The slope of the disease-free survival curves will be critical as we continue to follow the patients who went on these studies. And in North America, we still offer adjuvant chemotherapy for stage 3, most stage 2s, many of the stage 1Bs, you know, all those things that we use to guide who should get chemo and who shouldn't, that hasn't changed. Can MRD help us identify those who need surgery, those who only need chemotherapy, or need chemotherapy and a TKI for a little bit of time, or maybe need TKI indefinitely? So we still have a lot of questions to answer, but chemotherapy hasn't gone away. So I will end with that, so thank you.
Any questions?
Yeah, so I had three questions. Sorry. The first question is more, is a stage 1B EGFR biologically the same as a stage 2 or 3, which may explain the reason why some need chemo, some may not? The second question relates to better determining biologically who needs treatments after. Would a more of a neoadjuvant approach be more informative? I don't know if you hear me, but if the no, sorry. So my first question is a stage,
Yeah.
loud, sorry. Is a stage 1B EGFR biologically the same as a stage 3 EGFR, which may explain some of the discordance between who needs chemo, who doesn't? The second question is, to Dr. Wakely's point about trying to get more information about what to do after, is more of a neoadjuvant approach more interesting. You give your TKI, you have a certain response, you'll be able to have an understanding which cells are more resistant than others, and then determine whether you should do what you should do after. And the third question is, for an ALK patient, would you feel uncomfortable not giving chemotherapy after their surgery?
Great. And I think Dr. Zhang probably has some ideas too on this. So for the first patient in the biology of a stage 1B versus a stage 3 patient with EGFR mutant lung cancer, there are really two ways to answer that, right? One is, did we find the disease earlier in the course before the cells had developed the potential to metastasize to lymph nodes, right? I mean, it's kind of, how do we define that? Or did we just not look well enough? And they're really all the same. And I don't know that we really have an answer to that. I mean, I personally do think that many of our patients with the driver mutation lung cancers have a propensity to have metastases and micrometastases earlier in their course than I think patients who have the more traditional lung cancers that don't have that. I don't know that I could point to which papers prove that. It's just more of a sense of treatment patterns that we've seen. And so I think that to me is one of the arguments in favor of continuing with the TKIs perhaps longer, and I think speaks to why we saw the benefit even in the stage 1B patients, perhaps more than any of us would have expected. But I think we have a lot more to do to really be able to answer that, because I do think that there are a subset. I mean, I see them in my clinic, right? I had a patient last week who had a stage, I think 2 actually, EGFR mutant lung cancer that was resected 6 years ago, and she still doesn't have evidence of disease. But I also have a couple who got to 4.5 years, and then all of a sudden they had a brain metastasis. And so, I'm speaking on both sides here, because I think that we have a lot of questions there. Your other question was about neoadjuvant, and we're waiting for the NeoAdora data, of course, and Professor Zhang talked to some of the data related to that, and that question of can we give that treatment earlier and make a big difference, but also highlighted the data from UCSF. Jackie Rado presented at ASCO in 2023, that in the neoadjuvant setting, only about 15% MPR, really almost no path CR, so it wasn't as robust of a response as we thought it might be. We're actually launching a trial called the NEOLA study, which is giving osimertinib prior to chemoradiation for patients with stage 3 unresectable. And I think there's going to be a lot that we still have to answer there. And then the same was with ALK. And I personally am very uncomfortable just giving 2 years of alectinib to a patient with resected ALK-positive lung cancer. I would definitely give them chemotherapy. And I think that question of duration is one that we really need to continue to ask. And I think it absolutely is critical that the pharmaceutical companies continue to follow these patients and not just say, oh, we're done, 5 years, okay. That's not right for the patients, because it means that we're leaving patients with a wave of recurrences, I think, in a few years after that. So I don't know if you want to add.
And as for the first question about stage 1B in the clinical practice, we will consider some high-risk factor, including the Ki-67, including the sometimes in China, we will have NGS next generation sequencing. Besides the EGFR mutation, if the RB1 alternation and the SMART4 and so on, and we will have considered the TKI treatment. And actually, there's a global multi-center phase 3 trial about the ADORA 2 in the stage 1B, 1A is ongoing. And actually in China, sometimes we will have some clinical trial in the MRD guy, the treatment for the stage 1B. Yeah, yes. And you mentioned the neoadjuvant treatment is very interesting. That we all know that the neoadjuvant TKI, even for the third generation of the TKIs, the MPI and the PCI is limited. And we're also looking forward to the new ADORA, the result. And we also found that in some subset of the EGFR mutation, is more sensitivity to IO chemo in the better than the TKI. The subset including the squamous cell adenocarcinoma and PD-L1 high expression and RBM10. And actually, we found that exon 20 insertion is very sensitive to the neoadjuvant IO chemo. And the paper will be published, and we will have some perspective trial. And we also initiate a trial of TKI sequential IO chemo. First, 6 weeks of third generation TKI, and 2 weeks later we will have IO chemo. Thank you.
What about Canada?
Sorry.
Well, I mean, in Canada, we have provincial sort of jurisdiction in terms of what we can offer. I can speak specifically for Quebec, and I believe it's the case across Canada, that we have access to osimertinib in the adjuvant setting with or without chemotherapy, just like in the trial. We don't yet have access to alectinib, but whispers in my ear have told me that's going to change very soon. And so that's, I guess, the situation here.
Thank you. My friend here wants to ask the question, but I've been holding the mic for about 5 minutes. I really want to talk about that last abstract from Australia about the circulating DNA. That was the best abstract. I thought I watched all of ASCO. I think that's practice changing, and I guess the question is, what do you think, and how do we get our hands on that radar technique? Because if you could actually find someone on Aussie that was progressing 5 months before the scan showed it, you could watch them closer. You might have to come in with SPRT. You know, those are people that are probably potentially curable.
So I'm at Stanford, right, with Max Dean, so we do this all the time. We're very fortunate. I thought Elsa Ignacio's talk yesterday was brilliant as far as reviewing where are we with the ctDNA and the kind of the developments that are happening. I mean, I personally think that that's going to completely revolutionize the way that we care for patients. And this data that was presented by Tom John was really, I think, on a wide scale, one of the better, because so far we've had lots of presentations that are just, it's prognostic, it's prognostic, it's prognostic, and this one, to me, added a lot more. I thought it was really, really important data, but it's an incredibly challenging and expensive technique. They only had enough tissue to, based on the way it was done, you know, certain jurisdictions couldn't send in tissue to get the testing done. They were able to make the assay for 91%, but that means 9% they couldn't of the patients where they did it. And I showed you the numbers. I don't remember exactly, but like I think the sensitivity was only in the 60s, right? The specificity was pretty good, in the 90s, but it still wasn't good enough. And so we're moving there, right? The challenge you get to is that truly ultra sensitive, the risk of error is so high, and that's where the technology, you know, is so important. Is how do you get to those levels of detection that are so low without being misled by errors frequently enough that it becomes garbage. And again, Elsa, I thought brilliantly talked through all of that yesterday. So.
Thank you. Oh. I get to ask the question I wanted to ask before Barb. The question is for the two panelists. So it relates to the Laura presentation that we heard at ASCO. I'm starting to believe that prognosis for stage 3 in untreated patients after chemoradiation is really bad. I don't know which patients can be cured by chemo-RT in stage 3, but I'm beginning to think that not many are cured. So the question is, are we helping patients with chemoradiation in stage 3? Especially in tumor boards, we often extend stage 3 to patients with oligometastatic presentation. We radiate the single metastases, and then we do chemoradiation for the bulky intrathoracic tumor. Should we be only giving these patients osimertinib and follow them? What is your perspective? So is the question too long?
Stage 3A?
Yeah, stage 3, the question was, for a stage 3 patient, because there's such a high rate of recurrence with EGFR, the question was, in stage 3, because there's such a high rate of recurrence with EGFR, should we skip the the chemotherapy radiation altogether and just put them on osimertinib? So that was the question.
Actually, it's a very controversial. Yeah, the EGFR mutation stage 3A is very heterogeneous. And stage 3A1 is the accidental, maybe ADORA enroll some receptor accidental stage 3A, and the new ADORA may be enroll many potential receptor and downstaging than surgery. And ROLA study maybe enroll unreceptable. Actually, I think that it's very crossover in different hospitals. I think before the treatment, we should have the multidisciplinary discussion, yes.
Yeah. To me, I think that there absolutely is a role for surgery for earlier stage patients, and there absolutely is a role for chemo and radiation in patients with stage 3. And it's about getting rid of a larger number of the persister cells, a larger number of those, just cells in general with cancer. With the I try to simplify everything, right? And from a simple perspective, fewer cells, fewer opportunities for new resistance mutations to develop because you've got fewer cells dividing. And maybe that's just overly simplified way to think about it. But if you look at the curves that we saw from Laura, which were absolutely unbelievable at ASCO, and then you think about what do we see in stage 4, I think if we hadn't done the chemotherapy and radiation, those curves would be much more similar than they were. So that to me is the argument for continuing to be aggressive with that local therapy up front. I think that's probably part of why FLORA-2 was positive, is that we're wiping out more of the cells that were potentially resistant or we're going to be persisting, and then those are the ones that we're going to grow up into the clones that were resistant. That's kind of, again, simplified, and I'm sure there are people who would disagree with that, but.
Okay, well, that concludes this session. Thank you very much. I think John has something to add.
Thank you so much. I didn't expect, well, yeah. So this was a super session. I thank you, Dr. Zhang, for coming from so far, Dr. Wakely coming from Stanford. This was really good to get that kind of international perspective. So we've got about 10, 15 minutes if you can go grab some lunch, and we're going to start about 12:20 with the Merck Lunch Symposium. We're a little bit behind, but it's okay. We have an early finish today. We'll make up the time along the way. Thank you so much. No, it was fantastic.